Hello, everyone. My name is Ryan Severgen. It's my pleasure today to be introducing our speakers for Grand Rounds. Our first speaker is Dr. Greig. Dr. Greig is an assistant professor of general internal medicine with a dual appointment in civil and architectural engineering at the University of Miami. She's actually co-director of UM's Global Institute for Community Health and Development, and she focuses on global health, disaster response, and building resilient healthcare systems. She works with the Climate Resilience Institute, where she studies how innovative partnerships can improve public health in climate-stressed regions like South Florida, Latin America, and the Caribbean. She's also a graduate of the University of Pennsylvania and the University of Miami Miller School of Medicine. She completed her internal medicine residency at New York Presbyterian Cornell and earned a certificate of community preparedness and disaster management from UNC Chapel Hill. She was also on as faculty there. Currently, she's teaching climate, health, and disaster response across multiple UM colleges. Please join me in welcoming Dr. Greig.
Feel like we're under climate-related stress right now in this room. Thank you, Amber. Hopefully it warms up in a second, but that'll keep you guys awake through this. Right. So, my job really focuses around disaster and disaster response. So thinking about climate stress, I come in right from the exactly right from the back end of where we really think about kind of the nexus of climate and health, right? So once your environment has harmed you enough that I have gotten involved, a lot of systems have failed you, which is why the interdisciplinary approach that we take at Global Institute and across the university to think about healthcare and climate resilience. And I think, for doctors, that broad spectrum approach makes it very hard to figure out how to apply this within a clinical setting and within a healthcare environment, because a lot of the solutions are so far upstream of the healthcare system when you're thinking about climate and health that you think, like, as a physician, what is my role here? So I'm just going to talk briefly today about a couple approaches that we can think about in terms of how we think about this and how we teach climate and health in the curriculum here, and how we're kind of, this is a bit of an evolving landscape. I don't have any disclosures except to say that I work for a car company, and this lecture is about greenhouse gas emission to a certain extent, which is so that it won't be too preachy on climate change, which is the good news. What am I supposed to point it at? I couldn't do it on there either. All right. Okay. So this is how we think about disasters, right? So a disaster isn't just about a climate hazard, right? And the catchphrase right now is that there are no natural disasters, that there are natural hazards, and this is what we have to deal with here in South Florida. Unfortunately, we're a bit of a living lab for this particular environment, right? Because we are up against climate hazards all the time. Hurricane season is one thing, heat is another that we face a lot of, exposures and vulnerability. So adding climate and the environment to your social determinants of health kind of portfolio when you're thinking about patients is important here. But really, a disaster doesn't happen just because of the climate-related hazard. It happens because of the environment, the socioeconomic strain of your patients, their underlying conditions, and functionally how vulnerable you are to either an exposure, a hazard, or whatever. So like any social determinant of health, right? And those things, when they come together in the worst way possible, equal a disaster. So when we're thinking about vulnerability, like from a broad perspective, we're thinking about physical vulnerability, so your population density levels, the remoteness of your affected areas, and we work a lot in the Caribbean. So we're looking at remoteness of islands, which can be functionally like, rural communities, isolated communities. Your physical characteristics of your geography or where people live. So here we think about urban heat islands here in Miami, for example. Social vulnerability, obviously literacy, education, social equality, all those things that equal health from the outside. Economic vulnerability, and certainly where we have to think about our in our domain is access to resources devoted specifically to safety and the ability to withstand temporary setbacks or financial losses. So when you're thinking about it from a healthcare perspective, right, obviously this is, Dr. Weiss is a disaster responder in this particular domain, right? You have to be thinking about the system as a whole and how much of a financial cushion that you have to withstand one of these kind of insults. And obviously, when we're thinking about our environmental vulnerability, your natural resource depletion and degradation plays into a vulnerability across the board. So these are kind of the domains that we think about in terms of things that can ultimately downstream affect your health, but aren't really interventions that doctors can sort of make entryways into specifically. And one of the greatest predictors of disaster is if you have a slide deck due 2 weeks before your disaster lecture, certainly you will conjure something up that will have to be edited in later. And just to give sort of life to what I was just talking about, and the kind of new hazards and the scenarios that we face is obviously the incredibly unfortunate situation that we have in Jamaica currently. So this tropical storm, as it was on Wednesday, October 22nd, was kind of mulling around and came out of nowhere in a part of the Caribbean that we don't really think of as being kind of the nexus of where storms are generated. And then it kind of danced around for a little bit in a funny way, and then saw itself move all the way up into a Category 5 hurricane that then made landfall in western Jamaica. So this is part of what we're looking at, kind of the new climate stress. There aren't necessarily more hurricanes, according to our hurricane experts here at Rosenstiel, but rapid intensification is something that we have to think about more often now. And certainly that makes a difference in terms of our planning and what we get nervous about coming onto our shores here in Miami. And one example of how this has changed a little bit over the years and how we've thought about this is right when before I had started at the University of Miami, and the hurricane season of 2017 took a pretty hefty toll. Actually, here in Miami too, because we were hit by Hurricane Irma. But in Puerto Rico, this kind of changed a lot of how we think about health systems, how we think about disaster preparedness, and how we think about emergency response, and how we think about the duration and who needs to be involved in those kind of responses. And I'll give you this report, which is now infamous. Obviously, a lot of attention was paid to FEMA. And this happened during Trump 1. And actually, I think a lot of what's happening to FEMA now can be attributed to the sort of memory of what happened during this particular hurricane response. But this is part of this. This is part of this report. And you can see here on the left-hand side in the blue of the slide what FEMA's planning assumptions were around this particular storm or these two storms that ended up hitting Puerto Rico. So the planning assumptions that you can see there, and there is a danger in emergency response and emergency preparedness in over planning, right? So you cannot commit so many financial resources to everything where you become an impermeable fortress to these things, right? You do take a bit of a gamble, and over planning can cause as much trouble oftentimes as under planning. But you can see how far off the mark FEMA was for this particular summer and the impacts, right? So the population assumed to be impacted, they shot for about 50%. Ultimately, the actual impact in that season, almost 100% of people were impacted, and notably the power grid. So, it's no surprise to anyone that that Puerto Rico's power grid, especially now, has some challenges. But having lost the entire island power, right, and this progressed for months, it's hard to imagine how the rest of the impacts weren't also 100%, right? It's hard to have no power on an entire island and then have people unimpacted by that particular insult, right? But you can see how far off the mark the assumptions were from the actual impact here. And this particular paper that was published at the time by a colleague that we work with very frequently now was created a major firestorm in the media, politically. And what this paper is about is actually about the reported death toll of 63 people versus, the increase in mortality, expected mortality in the 6 months after the storm, that then they attributed going door to door by essentially storm impacts in terms of storm impacts that messed up people's access to downstream healthcare that ultimately killed them within 6 months of the storm, right? So you can see here the actual death toll of 64 down here, like on the bottom of the slide on the graph on the right. And then the excess mortality estimated from, reported deaths on the right from a couple different other estimate groups, right? And those are in the 4,500, 6,000 range, right? So the publication came out, and this is what was in the press, essentially saying that, some Harvard guys in the New England Journal said, actually, the government is saying 64 people died from the storm, and those are people that were swept away in floodwaters, trees fell on them, that kind of like dramatic storm impact. But the 4,000 to 6,000 people that died in the 6 months can be directly attributed to the storm. They missed dialysis, their supply chain got interrupted, they couldn't get their insulin. All those kind of metrics went into those cause of death numbers. And that makes sense to anyone who's been in a hurricane before or has treated patients in a disaster response, right? That's not news to us, I don't think, right? That if you have a major interruption in your ability to provide healthcare in your supply chain, if you have a vulnerable population and you can't fix those, like all those logistics, that people are going to become sick and die after that. So, but nonetheless, it was taken as a direct criticism of the hurricane response by the government that I think FEMA has kind of paid that price ultimately down the road by taking the fall for this. And the question is, like, how do we distribute our healthcare resources after an impact or during a storm? And this is a joke at the Global Institute because we are all primary care physicians, that if we do one more training that involves doing a field needle decompression, I told Barry Eisenberg I would donate, if this actually happens to me, that I am in the field with a needle in my hand with someone in front of me who needs a needle thoracotomy, I do it, I will give them $1 million because we've trained for it 1,000,000 times. I also told him that I would give him $10 million if I did it wrong after doing 10,000 trainings on this. But ultimately, where these kind of deaths come from is probably getting your blood pressure medication, right? It's not as cool, but it's where the money's at, in my opinion. So this is just a look at the ED utilization following Hurricane Sandy. Hurricane Sandy actually happened when I was a resident up in New York, which is another predictor of disaster, is hiring me somewhere, because a hurricane followed me from med school here all the way up into Manhattan. But you can see, the way that we staff hospitals and the way that we think about the response is that, right, that there's going to be an influx of stuff going into a hospital. And for certain emergencies, that's the case, right? Trauma-borne emergencies that we don't have a lot of predictive value around. But for hurricanes, hospital utilization really remains pretty flat. And this is in Manhattan, where you can go to a hospital on like every corner, basically. But you can see that, like, kind of the way that we think about the response, how we staff hospitals, there's a little bit of a disconnect on what actually happens in the hospital following a storm. And obviously, staffing a hospital, you have to be thinking about worst case scenarios and the fact that you can't get personnel in and out during the storm. So if you're understaffed at the time, then you're stuck with that particular metric. And the question is, like, how do we track people in hurricanes in particular to figure out where they are going to go? And if they're not going to hospitals, but they're dying, what do they need? Like, what service what's the intervention there that you need to put together? And it's very, very difficult to track where people are going, how they're going to behave during a hurricane evacuation. And this is data from Meta. So as you are Instagramming yourself going out from the hurricane into the Red Cross shelter, someone at Data for Good is tracking your progress, right? And actually, this was Hurricane Milton last year. And what this data ended up helping to show was that actually people who are in high risk evacuation zones actually in Florida heed those evacuation warnings. They did pretty well, right? There's always going to be some guy in the background on the Weather Channel, like playing a trombone, but you don't have to worry about that guy because he cannot be killed by conventional means. Everyone else actually is doing pretty well in terms of evacuating. But you could also potentially use this data to figure out how to staff up other hospitals that weren't evacuated, right? Because if you end up evacuating your area, including your hospital, then potentially looking at the volumes in other hospital systems, other primary care centers, people seeking urgent care in the peripheral areas on how people behave in an evacuation. That's helpful data because other places outside of the zone that are unaffected may actually have to staff up their operations, whereas people within the zone can sort of tamper down the expectations for what's going to happen within their affected area. And apologies for not having the citation here. It's like tucked behind the slide there, I think. But this is hot off the presses in JAMA from 2 weeks ago. So this is actually going back to Hurricane Sandy and looking at the data of cardiovascular risk rates in the 2 years before to 5 years after Hurricane Sandy landfall. And again, this is in a very high density area of access to healthcare in theory, right? And what it showed was that across all regions and those are by zip code essentially, for cardiovascular disease, generally speaking, you are at higher risk people were at higher risk based on Medicare data for having cardiovascular disease following the storm if they were in an impacted, flooded area. And other outcomes that are worse only in New Jersey. So you can insert your New Jersey joke there, but essentially, and this does go along with other data that shows that, and to be in the study, you actually had to have stayed in the same zip code the whole time. And that kind of does jive with the protective factor of actually leaving a disaster zone, even if you were in the disaster zone to begin with. If you move, there are some protective factors to your health that portend better outcomes if you just kind of get out of there. So when we're thinking about climate change and the new variables, we do think about being role models down here in South Florida, because as goes Florida, so goes the world. But when we're thinking about, and this is a picture in Asheville, North Carolina, where they did not see inland flooding coming as part of a hurricane that made landfall hundreds of miles away in Florida. And thinking about the complexity of the topography, the complexity of movement of both people and storms, and unprepared populations, and the rapid intensification that we talked about before, how that can be disruptive to places that haven't experienced this kind of climate kind of hazard before, and what we have to think about in terms of health systems and healthcare and how we deliver it, and what we're really thinking about in post-disaster emergency care delivery. And I put a picture of a Walgreens in there. Pharmacy supply chain disruption and closure actually drive a lot of the downstream mortality, right? So thinking about how you have access to your medications and the pharmacies and everything like that are of paramount importance. And then, like, your actual clinical, practical application. You are face to face with a patient in your office and nothing bad is happening in the surrounding area. Do we actually practice thinking about climate and health? And the answer in my practice is kind of not really. But, if there 6 million deaths that the Lancet last week is attributing to air pollution globally, right? Is that something that we're missing in terms of clinical practice? That, like, do you practice like this as in whatever? But everyone in pulmonary is like, yes. But thinking about this isn't totally on my radar, even though it's a major clinical scourge, right? So these are all graphics from the Lancet report from a couple weeks ago on health and climate change. And there are tons of them like this, but this one in particular, we have to think about a lot here in South Florida and probably don't as much as we should. So heat impacts obviously our bread and butter. And there is a major push in Miami-Dade. We used to have a chief heat officer for the county, and now that position still exists, but it's been rolled up into like 4 other positions, all of which sound enormous to me. So I don't know how much attention is really being paid to it. And attributing deaths to heat, I think, is a very important nexus for where we think about treating patients, but also about advocacy for patients, in terms of what physicians can do in terms of being an advocate, in terms of, thinking about climate impacts. In particular, we're thinking here a lot about occupational health exposure. So patients that have outdoor jobs, obviously, in South Florida, that's a danger in and of itself. And the underlying conditions that you're thinking about in terms of their impact and heat can shorten patients' lifespans dramatically. So this is actually a very helpful tool that was developed by AmeriCares and also the group at Harvard. And it is like a very practical and I would say like kind of visually appealing and simple toolkit for both patients, has like checklists for your patients that are at higher risk, emergency preparedness stuff that you can have your clinic staff review and make sure your outpatient clinic or inpatient facility is kind of staffed up and prepared for these kind of health risks. It goes through ones that are, health risks more nationally. So there's wildfires and stuff like that we don't typically deal with here. But heat is one of the larger things that's on here. Oh, wow. I made a video. I forgot about that. One very practical application about thinking about heat is the impact of people's medications and their ability to thermoregulate and heat sensitivity of the actual medication itself. So when you look through this toolkit, I encourage everybody to just take a peek at it. And there's a lot of pushback about like how we add climate and health into your actual clinical application. I would argue that this is a one-time take a look at it thing, and then it'll be top of mind and you won't really have to think about it or do CME or whatever. But it's important to have this kind of at the top of mind, particularly as it relates to all kinds of medications. And, in everybody's practice, we're all dealing with SSRIs and mood stabilizers. And like, if I said it once on Fisher Island, I've said it a million times. Don't go out and play pickleball on cocaine, but there's lots of things that there's lots of things you can do. Now, obviously there's things that you don't really have to think about all that much, right? It doesn't take a huge mental leap to understand that if you're on a diuretic or your SGLT2, that heat is going to impact you more. You're going to be more likely, particularly if you're an outpatient worker outdoor worker, to get dehydrated, downstream kidney disease, fall off a ladder, like that kind of stuff. So they have this whole list of meds. They have patient information. They have checklists that you can go through with your patient for almost any kind of climate stressor, either an acute one like a storm, risk of flooding, evacuation stuff for high-risk patients, but also your day-to-day kind of metrics. So in terms of a practical application for clinical practice, I would highly recommend taking a peek at this. And then the final thing that I want to mention is climate change and health education. So this was also not really on my radar of things that we need to do. But this is really coming from the bottom up push from our students. So our students here did a poll both internally at UM and to external medical students about the interest in climate and integration into medical education. And there's like almost universal interest in this from our medical students, and almost no kind of like faculty level understanding of the problem. And I too am in that. I too am in that zone. So we're in terms of the integration into the education components. We're trying to integrate these kind of teaching, like every single lecture to have a little bit of climate impact on all of those things, with the hope that then we get a more climate literate generation of physicians coming up through the pipeline that can both advocate for patients, advocate for the environment, and help their patients navigate a changing climate that's going to be ultimately more impactful on their health downstream. But making the link between climate and health consequences is viewed from the environmental perspective as like the holy grail of actually moving the needle on having people care about environmental impacts, right? Because even if you're the most downstream practitioner, if you're the physician that says this is harming you directly, we have data to support this, the idea is that that goes back upstream and more people kind of care about the issue based on what the doctors all say. So that's what I have about that, and I'll take questions. Where are they?
Thank you, Dr. Gray, for that great grand rounds. Maybe I'll begin by asking a question first. So what would you suggest is the most impactful thing that an academic health system like ours can do during an acute disaster? Oftentimes, especially most recently with what's happened in Jamaica, the whole concept of, oh, we got to give money, we got to go there, we have to provide supplies. And everybody has certain limitations in terms of resources and so forth. And of course, in a disaster, we have a great, I saw Vince here in the audience. Is he still here? There he is. So, I mean, Vince keeps us protected, our patients protected. But what is it that we as an academic health center can do for the world is the most impactful thing you think?
I think the understanding of the duration of impact of disaster is really key. And I think what happens is that, it's in and out of the headlines quickly if it's a dramatic disaster, and the impacts are so far reaching that really not thinking about how long the insult is actually going to last for that particular population. So if it were to happen here in Miami, I would say, and it has happened here in Miami, right? We had COVID. I mean, everyone in this room is now a disaster responder after going after this. And thinking about, there's an immediate rush towards the kind of, which makes total sense, the most acute thing, and focusing on the inpatient sickest people. But the impact over a public health zone is probably going to be about keeping people safe more on the ambulatory level. And I think that gets missed almost everywhere in disasters. And the other thing that I would say, which is actually why it's a great place to work in an academic health center and think about other people's disasters, is that you don't have to be the first boots on the ground. As we all know, academic health centers are not the most nimble place in the universe. And you can make a tremendous downstream impact with medium to long range interventions that are like longer term partnership and helping think about the developing resilience in healthcare systems and healthcare delivery and education, all of which doesn't have to be a hair on fire experience. But the acknowledgement, I mean, we've been working in the Bahamas since Hurricane Dorian, which was an acute response at one point, but now has gone on 6 years, and we still have active programs that are really focused on helping them recover from that particular storm. So not giving up after the first couple of weeks, I think, is what we do best as an academic health center, but we have to think about that internally too, that the downstream consequences of anything that hits us that feels like it's going to last a few weeks actually doesn't. It lasts a long time.
Thank you, Dr. Greig.